Great. So welcome to this COVID-19 session. Let me introduce this session. All the presentations refer to 6 different chapters of the current Handbook of Labor, Human Resource, and Population Economics, which is edited by Klaus Zimmermann. I'm proud to be the section editor of COVID-19 in the Handbook, and I'm super happy to have been able to organize this amazing session. It's the second time we organize a COVID session. The first was organized within the previous Eurasian Business and Economic Society conference with 6 other different chapters of the handbook COVID section. First, I would like to thank Klaus for asking me to organize this session and for the continued support in the organization. Thank you all the organizational committee of the GLO for organizing this amazing world conference and for hosting this session. And obviously, thank you so much to all of you for accepting our invitation to present the main result of your service. We're going to discuss 6 different aspects of the COVID-19 consequences in the labor market. All the presentation and the chapters contain a complete review of the very recent and current increasing literature on these aspects of COVID-19. You have, let's say, 15 minutes for the presentation and 5-6 minutes for the discussion comments. I think we can start. There is small change in the order. Guglielmo Briscese is the first presenter. Actually, he's in Chicago in the year, so it's about 1 a.m. So again, Guglielmo, let me thank you for being here at this time for you. Guglielmo is a postdoc fellow at the University of Chicago at the Inclusive Economic Lab. So please, Guglielmo, the floor is yours. Thank you.
Thank you. So I'm gonna share my screen. All right, give me 1 second. Okay. Can you all see my slides?
Yes, that's perfect.
The full screen ones?
Yeah.
Beautiful. Okay, thank you. Thank you so much, Sergio, for having me, and thanks everyone again for accommodating my time zone. I'm Guglielmo Briscese. I work at the University of Chicago, and I'm going to present today a brief summary of the literature review that we were kindly invited to write up for the handbook, and it's specifically a review about the drivers of compliance with the social distancing measures at the time of COVID-19. This is a work that is also based on an ongoing collaboration with other co-authors, which are listed on this title slide: Nicola Lacetera from the University of Toronto, Mario Macis from Johns Hopkins, and Mirco Tonin, who's at the University of Free University of Bolzano in Italy. Social distancing measures, we are now all quite familiar with it, and I think it's fair to say that virtually almost every country implemented some form or another of social distancing measures at some point during the pandemic. This was particularly true during the early stages of the pandemic, where we didn't have vaccines, we didn't have medical treatments, and doctors in most countries didn't know quite well how to treat patients, and the evidence that was coming between January and March 2020 was mostly from 2 key countries, which is China and Italy. And so a lot of countries ended up sort of like coping, implementing coping mechanisms and coping Italy and China in that approach. We are now 3 years almost since the first case, if you consider that actually the first cases were detected in November, December 2019. And doesn't seem like the pandemic is still quite over yet. We're still dealing with high number of cases sometimes, especially now that we're getting into winter season. The news coming from China are quite worrying about exploding number of cases and deaths, again, in Wuhan and many other regions. And so it's worth, I think, going back, writing up this chapter was really useful also for us as researchers to sort of like question our findings, question our own priors, our own beliefs, and see sort of what we can learn from what the countries around the world have been doing. And I think to this day it remains still a key policy. We don't know whether in the future, hopefully not, but if there will be other pandemics, then it seems like the very first response the governments are willing to implement is social distancing or harder lockdown sort of measures. From a research point of view, the silver lining, if you want, of these dramatic events is that we actually now have quite a lot of comprehensive evidence coming from all these countries, that there's more than 90 countries that we counted have implemented some form of social distancing measures at some point. So we actually and they all implemented it in different ways. So we have quite a bit of evidence that allows us to sort of compare maybe, what could have worked and what were the drivers behind these social distancing measures and the drivers for compliance. And the key finding, if there is one thing that you can take away from this, is there's actually very little evidence on the cost and the benefits of this type of interventions to reduce social distancing, to increase social distancing during a pandemic. So we actually, despite all these worldwide adoption of these measures, there's very little evidence on what works to encourage people to stay at home. And when you actually go through the cost-benefit analysis of the social distancing measures, it's still very, very difficult to estimate whether they were worth it, whether they weren't, and in what cases they sort of passed the cost-benefit analysis. So in this chapter, what we did, we summarized the drivers of social distancing measures compliance. So basically, what are the factors that help citizens comply with these measures and stay at home, or comply with the lockdowns? And we summarize them in 4 or 5 key broad areas. And I'm going to summarize them now, one per slide, with just 4 or 5 slides, and then I'm going to conclude. The first group of drivers that we identified in this review were what you might call intrinsic motives, which is essentially anything that is individualism or prosociality or civic capital. Essentially any attitude the citizens might have from their own behavior or beliefs to comply with social distancing measures without much of an enforcement, without much of an incentive or penalties, from the government, or too much effort in terms of communication from the government. This is probably not too surprising if you think about it. Areas that have high social and civic capital and high levels of prosociality are usually correlated with better economic outcomes and socioeconomic outcomes in general. They tend to be areas where people are more law-abiding, they recycle more, they get fewer fines. So it's not too surprising, perhaps. What is interesting is that this is quite consistent across a broad range of cultural context. These are just 3 of the few of the studies that we mentioned in the Handbook chapter. There is a study that was widely cited in Sweden that sort of finds this correlation between high levels of prosociality at the individual level with higher compliance with social distancing measures. There's another study that did it in US counties and some European regions, finds also a strong correlation. And then there is another paper by Durante, who I think is at Pompeu Fabra, that does it in Italy and Germany. And they find very similar sort of correlation. And so the interesting thing here is that it doesn't matter what sort of context you see, at least this is coming from Western countries. It really seems like, the individual attitude sort of play a role. The other broad area, the other thing I should flag is that I can't see the comments right now. So if there are questions, I can answer them at the end. But if there's something about timing, Sergio, feel free to interrupt me at any time. The other group of drivers that we identified and wanted to summarize in the chapter is the role of information and beliefs. During the pandemic, citizens relied on multiple sources of information, not just what was coming from the government or the news channels, but these sort of conflicting sources of information sometimes, their own friends, their own social networks, the social media that they were using, sometimes were sending conflicting messages compared to what the government were saying, right? For instance, compared to the announcements from the government. And the few probably key findings or key studies in this area come from, for instance, this paper by Charon Wang and others. They find that in the US counties, they had a higher prevalence of people coming from China or Italy living in the US, or people living in the US that actually just had more friends or connections with China and Italy at the very early stages of the pandemic, just had higher compliance with the mobility restrictions. So they tended to stay at home a little bit more, just because they probably were receiving the news, right? They were being shared on social media from China and Italy. But when you actually try to encourage it and enforce it, like this study that was done was an experiment done in Zambia by Burland and others. They actually asked people to send text messages to their own friends to ask them to comply with the social distancing measures that actually didn't seem to have translated in actual behavioral changes. And then there is our paper that, with some shameless self-promotion, I had to put in there. This was like, quite a popular paper. A lot of media outlets decided to pick it up. This was like one of the first probably papers on COVID-19, were more than what we expected, I might say. And this was a survey that we did on the Italian population, where we basically gave them information about the announcement of the length of the social distancing measures implemented by the government. And then we gave them a bunch of scenarios about the potential extensions. In reality, the government ended up extending the length of these measures for, quite a few weeks, at least more than 3 or 4 times. So they kept announcing a date and then they extended it and extended it over and over again. But what we found is that every time that the government was announcing an extension, they were increasing the probability that people will stop complying. Or better, when the extensions were longer than what people expected at the very beginning. So when there was this mismatch between expectations and announcements, the willingness to comply will just drop significantly. The other sort of low-hanging fruit that a lot of governments tried, especially the ones that had a behavioral insights unit embedded within their own governments, were the so-called nudge interventions, essentially like low-cost interventions that may be informational treatments. Sometimes it would be like flyers, sometimes it would be like text messages, emails, anything that you could summarize broadly in the popular culture as like nudges. The finding from this review is that they actually don't seem to be quite effective at changing behaviors during a pandemic, not just when it comes to social distancing measures compliance, but more broadly. Maybe again, and the interesting thing is that this is quite consistent across countries and different types of implementation modes. So this is probably telling us something. This is an area where I spent a lot of my career so far on nudges and behavioral insights applications. So I was quite interested in understanding why. And we summarize the reasons why we think nudges are not effective in a pandemic in the chapter. But we think is that in general, you can expect nudge type of interventions to really be marginally significant and only in some context. The pandemic is probably quite difficult. It's quite new. And we don't know quite yet about how people behave. The other thing is that a lot of these studies were implemented in like spring, summer of 2020. So this was already quite after like 2 or 3 months after the first lockdown measures were implemented. So it is possible that by then people already formed quite strong beliefs about whether they wanted to comply or not, whether they wanted to get vaccinated or not in the future. And so it was going to be quite hard to then change those behaviors if we were living in our own little bubble. And the other one is that some regions just had very high levels of compliance for a reason or another one. And that on top of that, you might have high, isolation fatigue. It is true that lockdowns actually took, a toll on mental health and economic health for some households and some families. So it is quite difficult to shift those behaviors when you have these sort of like barriers. I won't go into the details of these type of interventions. They are summarized in the chapter, but the interesting thing again is that there is, consistent evidence that don't seem to really be that effective. And then the other sort of group of drivers is really like the original, if you want, more traditional policy levers that governments have available, right? Which is incentives, fines, and rewards. Essentially, like the fines that you give to people for not complying, or the rewards that you give to people to encourage them to comply with lockdowns and social distancing measures. One thing that is now becoming more and more clear, and it is true that probably some commentators and some economists sort of did flag these earlier on in the pandemic, but it is now becoming more clear that social distancing measures did have costs. They introduced costs in the economy. A lot of businesses have closed permanently. A lot of families lost their sources of income, and the very sad reality that is emerging from these studies that are sort of measuring the aftermath of the pandemic is that it also exacerbated pre-existing inequalities across all domains around, gender, race, income, job stability, and so I think we have to sort of consider the fact that when people were not complying with these social distancing measures, in hindsight, maybe it is because they were also more aware of the fact that it was a high cost, right? It was very difficult for them to comply. On the other hand, some traditional policy levers like hefty fines actually seem to work. So if you're really in a scenario where you want people to comply, it seems like some evidence coming especially from Germany. There is one study that shows that there were some fines up to $25,000, I think, in Bavaria. If you didn't comply, they did have an effect. So in those regions, actually, the growth rate of the virus decreased and the number of cases went down, and I think the death rate went down a little bit. But what we do know is that the economic cost was also quite substantial. A lot of governments obviously tried, I think we're aware of this, and they tried to implement measures to counteract the cost of the lockdowns. One of these was sending subsidies to people, checks directly to households. They don't seem to have worked that much. These sort of benefits are very, very difficult to deliver in a timely fashion. It's very difficult to identify exactly the people that need that money. It's very difficult to contact them. A lot of the people that are at the margins of the labor market, they tend to work cash in hand type of jobs. They tend to be also more likely to live in difficult situations in areas that sometimes don't even have internet. And so the risk is that when you just have these helicopter money, if you will, to call it like that, sort of dropping on families, trying to help them in terms of crisis, the people who are more likely to benefit from these type of interventions are the ones that probably would have survived, the crisis anyway. So businesses that are quite well established, families that are probably not on the lowest of the income distribution. Going back to some of the media outlets and newspapers again, we sort of knew some of these things. We sort of knew earlier on that these measures were costly, but we still had to do it because obviously, the evidence back then was, this is scary. We don't know what's going to happen. We don't know what are the consequences. We still don't know, I think, fully what are the consequences of contracting the virus or letting it spread. But I think it is worth now, with more evidence to sort of sit down and sort of trying to understand why sometimes these measures might not have worked, why people were not willing to comply, and sort of understand or appreciate that rational economic decision-making might be at play sometimes. So just to conclude, as I said, most countries around the world adopted these social distancing measures to reduce the spread of COVID-19, especially earlier on when we didn't have vaccines and medical treatments. The intrinsic motives seem to be probably the strongest drivers and predictors of a higher level of compliance. We know also that government communication is quite important, especially when it has to counteract other sort of sources of information coming from not well properly established sources. And we also know that the way the government frames their communication is really, really important, especially to gain the trust of citizens, that in a time of crisis is the most important, most valuable asset that you can have. We obviously know that traditional policy levers work better than low-cost nudges or behavioral informed interventions. The question again is whether they are worth it in the long run. We have this growing evidence of the cost, and the benefits are still sort of difficult, to make sure that they reach the intended recipients. And basically, the key conclusion coming from this is that given that we have such a comprehensive evidence coming from all these 90 plus countries that implemented these sort of measures, given the richness of the data that we have on COVID cases, on the economic aftermath, I think it is time that as researchers get our hands dirty on doing some cost benefit analysis to really trying to understand what worked, what didn't work, and why, and how we can best use that evidence to inform policy making decisions in the future. So
thanks so much.
That's it.
Thank you very much, Guglielmo, for your very nice presentation. Is there any comments from the floor? Yes, Jonas, please.
Yes, so I wonder a little bit about, since this was such a long-lasting occurrence, and especially in the first, I mean, we didn't know that the vaccines were going to be so fast. And I mean, how is there any like evidence on how like compliance over time developed? I mean, it seems like this coming from Sweden, they had in mind like this was going to take a very long time already from the beginning. Therefore, they were quite reluctant to go really, really harsh in the beginning, maybe through a fault, and especially because the vaccines were faster than expected. But how do you get people to comply in the long run? Like how do you, both when it comes to actual compliance, but also how to do the cost-benefit analysis? Have you given that any thought in your review?
Yeah, so if I understood correctly, your question is like, how do you account for vaccine availability, but also like the expectation back then of when vaccines were going to become available and how that might have affected compliance, but also like government policy. If I'm not mistaken, there is one paper that I think is not included in our review, but that does try to do exactly what you said, which is basically like anticipating vaccine availability and see whether that has an effect on social distancing measures compliance. So it'd be interesting now, on top of my head, I recall the existence of the paper, but not quite what the paper, who are the authors. So if you find it, please share it. I think you're right. Back then we just didn't know, and so I think we were all, we as like government agencies and advisors were all in the sort of damage control mode. We were just trying to implement these sort of policies that seemed like the best solution we had available at that time. In the presence of vaccines, I think we're now going to have the challenge of trying to understand how sustainable some of those effects are of the vaccine, and hopefully, whether we're going to have to re-implement some of these measures again. That is an open question.
Thank you so much. Is there a question by Deirdre?
Hi there. Thanks very much. That was a really interesting presentation. I want to ask you something about what you said about nudges not being effective. And I guess this is a broader question about what you think about, the way this conversation is developing, not just to do with your papers. So, you said behavioural interventions were not effective. And I know that there's been kind of an ongoing debate with various reviews about whether a nudge is or is not effective. I wonder to what extent, when we try and analyze these things as nudges, we're throwing so many different things into one pot and trying to analyze them as one thing and then saying there's no effect. We're just introducing so much noise into trying to measure something. So, for example, to me, there's a world of difference between sending someone an information leaflet, which most evidence would say isn't that effective, and if you're in a different context, putting arrows towards a hand sanitizer or making hand sanitizer salient. And to what extent you can actually define them as one thing and then look at the outcome. I wonder how effective it is to be, with this ongoing conversation, to be defining nudges as essentially anything without considering the outcome that we're looking at and considering what nudge, I'm not even sure the word nudge is right, what type of intervention we're looking at. And just wondering what you think about that in terms of social distancing. I mean, do you think that it is the right way to define any behavioural intervention, to throw them all in and then look at them across divergent outcomes in different contexts? So to answer to the last part of the question first, we only reviewed obviously interventions, low-cost interventions, let's call it nudges just for our internal communication, related to social distancing measures. So obviously these were interventions specifically designed to track and monitor and measure outcomes related to social distancing. And there's a few papers like the ones that I have on this slide, for instance, they were not looking at, other outcomes. Going back to the first part of the question, I worked at the Behavioural Insights team, the UK BIT, for 5 years, and I am now quite aware of the pros and cons of some of these type of interventions, and I faced a lot of these challenges myself.
obviously you never know whether your interventions, given the small cost they have, whether they have any benefits at all on outcomes that you might not track actually, right? So you might actually see that arrows pointing to the hand sanitizer might probably not work depending on if you measure how much of the hand sanitizer is being used, but maybe you don't know if a week later people process that information, and actually they start using hand sanitizers, right? Or whether that information together with government communication that was released a week later actually kicked in that behavioral change, right? That you just don't track. So, but we will never know these things, right? That's the reason why we have to sort of pre-register these experiments and just specify exactly what type of outcomes we're tracking for how many people, and what are the mechanisms that we think are at play there. And when you look at these sort of pre-registered trials, measuring exactly, in this case, only like social distancing measures, the evidence seems to be that they are either very small or null effects. That doesn't mean that nudges don't work at all. It just means that, they sometimes work, sometimes they don't. Sometimes we have to look at the heterogeneity effect. Maybe they work for some people, but not for others in some context. Overall, it seems like probably in a pandemic when, it's for some people, it's a life or death situation. For some people, it's like death if they contract the virus. For some people, it's economic death if they don't find their jobs, you don't find money at the end of the month. In those cases, maybe like information treatments or, small type of interventions might not necessarily work that much, at least not on their own. That seems to be my impression.
Thank you, Guillermo. Thanks so much for your reply. Sorry, we are late. Thanks so much.
Thank you.
Let me go to the second presentation by Jonas. Thanks, Guillermo. Jonas, the floor is yours.
Guess I should unmute myself. So, hi, I'm Jonas Vlachos from Stockholm University. I've written this this chapter together with Helena Svaleryd from Uppsala. And we asked questions related specifically as to one intervention, that is the school closures. And our take on this is that we asked 3 different questions, or try to review 3 different questions. Like, what is the effect of school closures on virus transmission? That's the first. Then on student learning, and then on student mental health. And we restricted our attention to basically studies from OECD countries because the evidence from other countries might be suggesting that it's more severe, but it's like very scattered bits and pieces of evidence here and there. So we basically restricted our attention to the OECD countries. But as everyone knows, so it's also a huge reduction in the number of school days. So this is a graph from the OECD, maybe a little bit small in print here, but that number of school days lost at different levels of education, basically K-12 education. We didn't spend much time on higher education because there was so little research on that at the time of writing. But the number of lost school days throughout the world was very high in most countries, but also with a huge variation between countries. So going to the questions. Well, first of all, it has to do with like the underlying reasons for having school closures is to reduce virus transmission, of course. And there was a very initial hesitation about like how much did school-age children actually drive, if they even could transmit the virus. It had partly to do with the thing that the children luckily had very mild symptoms, so it made it difficult to detect. But after some hesitation, it was discovered that they actually could transmit the virus. But it was also the case that schools closed even prior to that information, I would say. And then when you look at the theory about virus transmission and school closures, there is a lot of evidence or a lot of discussion, theoretical modeling and so on, based on the influenza, which is an open question of how relevant that was for the COVID transmission. But it's not that clear that school closures are effective, even if children transmit the disease. So first of all, of course, I mean, you have to reduce, school closures have to reduce the actual number of contacts. So if children continue to hang out together outside of school, you won't do very much. You can even make things worse by having a less stable pool of contacts when you socialize outside of school rather than within the school. It also needs to be the case that the reproduction number has to be relatively low. I mean, say that you have like reproduction number of 15, then it's pointless trying to reduce it. So it doesn't make a difference in the end if you close the schools or not. So, and it's also more effective if you have a higher attack rate among children than adults, which you didn't in this case. So theoretically speaking, it was like unclear whether or not this would be an effective intervention of, and it's also clear from this very brief theoretical outline that the effectiveness will probably depend on other types of restrictions and local conditions and what exact virus type that you're talking about. There's probably not a deep answer to the question of whether school closures are effective, but it's like circumstantial. Sometimes it might be, and sometimes it might not. There are huge methodological issues here, especially with the early type of studies that came out as being cross-country or cross-regional, basically diff in diff, trying to run regressions, controlling for other factors, and then add a dummy for whether or not the school closure was introduced. And that research indicated a non-trivial decrease in infections from school closures. But of course, this is very problematic because closing the schools is an endogenous response to the prevalence. You don't close schools if the virus is not around. And they also almost always went hand in hand with many other restrictions that were introduced simultaneously. So it makes it very difficult to isolate the effect of school closures. So then came this some quasi-experimental evidence using various idiosyncratic shifts in school closures. So I have a study with colleagues that looked at partial school closures. In Sweden, we closed the upper secondary schools, but not the schools with younger children. So we compare families with children in upper versus lower secondary schools. It was also a bunch of studies looking at the start and end of school breaks, arguably because there's a difference in time in there when exactly they're supposed to close and open for summer break and so on. And the results from this literature is somewhat mixed, but it suggests that the impact of community transmission of having the schools closed is actually quite limited. I mean, our study, for example, finds that there is a reduction, but it's small. And it's even a more recent paper that wasn't included in our review because it came out too late. It shows that open schools can even mitigate transmission. The authors argue that it's probably due to better tracking and monitoring of disease prevalence when you are within the schools. But that, of course, depends on what type of precautionary measures you actually have in the schools. This was done in Germany, and they had a lot of like testing and tracing of cases there connected to the school openings. But there you actually found that they reduced the number of cases in the community as a whole by having the schools open rather than closed. But then there's also that teachers and their partners were quite severely affected when it comes to the disease. So, I mean, if this would have been a very dangerous disease, I guess the schools would have been closed anyway. But you can see that as expected, somehow teachers were not unaffected by having the schools open where you had them open, but the overall effect of the transmission was quite limited. So, and this is, as suggested by theory, not surprising. It is what you would expect. Like if the level of community transmission, say that it is around like 1.1, the reproduction number, and you close the schools, it might be just enough to reduce it to make an effect. But if it's very high, then it might not make a difference. Also, if it's very low, it doesn't make sense to close the schools. And it also seems there's quite a bit of body of evidence suggesting that the precautionary measures taken within the schools, both contact tracing, if you limit like class sizes, increase ventilation, and so on, that matters. And the age of students, that the older students are, the more they transmit. So, I mean, it's very, since this, as I said, this is not a deep parameter, the effect of school closures, but it depends on a lot of factors. But I would argue, based on the body of evidence that the effectiveness of closing the schools, especially for younger children, is questionable, precisely because they transmitted the virus to relatively much less. Another big question is the school closures on attainment, which is the big cost involved here, that students, there's a large pre-pandemic, I mean, normal literature of economics of education or education in general showed that students actually do learn in school. I mean, that maybe not that surprising you find it, but the effects are quite big. And it's also that on average, remote learning is substantially worse for learning than normal in-person schooling, and especially so for disadvantaged students. There's also huge differences in the digital preparedness across countries and also within countries between schools. Typically, digital preparedness is, well, it's high in some countries and low in some, like Germany is an outlier, I think, for being a developed country when it comes to low preparedness. The Netherlands and Sweden are very high on digital preparedness. There's also huge differences within countries, and typically there, you have that the children's schools serving less advantaged children, disadvantaged children typically have lower levels of digital preparedness. So remote learning is probably worse for disadvantaged students, and they are also at schools who are on average less prepared to do as well. So you have some very strong priors here about the effects. But there is a lot of methodological issues involved with trying to judge the impact of learning, and it partly boils down to that the standardized test as part of the pandemic response, a lot of standardized testing was cancelled. So it's very difficult to compare what students learn before and after and during the pandemic. There's been quite a few studies on trying to use various digital tools to track the progress of students, but they are very difficult to evaluate because there you have this that you actually get better at using these tools as you go along. So does any change in learning, does it really reflect learning or just getting more accustomed to like taking tests on the computer instead of in pen and paper? There's also in many places been large changes to the pools of people who actually take the test. In the US, there's been a lot of people dropping out of the schools all completely, which means that those who end up actually taking tests are quite different from those who used to take the test. And this is a problem that's especially severe when it comes to these digital tools, where you're a lot of moving in and out of using them, and they are completely non-random. Another issue, again, as for most intervention, it's difficult to isolate the impact of school closures. Other non-pharmaceutical interventions can also affect learning, like having your parents at home might be good or bad, depending on where you stand, can also depend on the age of students. Therefore, there's also been quite a few studies on trying to look at, rather than just looking at the output of test scores or something like that, they try to look at input into the production function of education. So time of study and how many library loans that are done, and how much different learning tools are used and so on. I would say to summarize the evidence, I would say they very well, largely, I would say they support the expected impact. There are a few very good studies on this, managed to exploit some quasi-random variation in test taking and so on with different timings in relation to the school closures in respective countries. And they indicate, well, very substantial learning losses and widening attainment inequalities as expected. It also suggests that the learning losses are larger for younger students. And these studies that try to look at inputs rather than outputs tend to yield very similar results, that there is a loss of input and unequally so across different social groups. Then I should say that there is a non-trivial amount of dissenting research using these online tools to evaluate learning progress. As I said, that could reflect other matters like adaptation to using these tools. But on the other side, it could also indicate that the very substantial learning losses indicated by these using more traditional standardized testing, that at least to some extent it could reflect that students are less prepared for taking the test. I mean, there's a lot of teaching to the test going on, it's an open question how much learning that actually gives compared to learning the subject matter but not actually teaching to the test. So there is some caveats to the main conclusion here that are we seeing real learning losses, or are we observing less pure test prep? And there I think you have to go.
Sorry, Jonas, you have 2 minutes to close, please.
Yes.
Yeah.
And then we have the issue of school closures and mental health. There has been a lot of concerns about that, largely based on pre-pandemic studies that showing that isolation is negatively correlated to student well-being, therefore drawing the conclusion that closing the schools might increase isolation, therefore reduce student well-being. I would say that this research is largely uninformative about the impact of school closures, partly because the research itself is poorly identified. But you can see that there is a lot, but there are like both positive and negative aspects of closing the schools. You can increase stress in some dimensions, perhaps due to less learning, but also it can reduce stress in several dimensions. That you get more time, more sleep, less social pressures, and so on. There are some studies looking at the trends during the pandemic. They're very inconclusive and point in different directions, depending on exactly what you look at. There are some quasi-experimental studies. They indicate worse well-being among younger children, but I again have a study with colleagues showing better outcomes among older students. These studies are hard to compare because one set relies on parent reports of student well-being. Our study relies on healthcare diagnosis and prescription drugs so it's difficult to compare. It could be that you capture parental worry more than anything else when it comes to the parental responses. It could mean that we in our study measure reduced access to health. There are also quite a few studies showing that there's less bullying going on. So cyberbullying and normal bullying seems to be complements rather than substitutes. I'll skip this. Oh, sorry. So it did help to reduce transmission, less so with the preventive measures and among young students. There seem to be quite substantial learning losses, especially among the worse off students, and that remote learning works better for older students. A big caveat is that vocational training, which might be very important for long-term employment prospects, that is almost essentially unstudied in these papers. There's no paper on how vocational training fared due to the closure. It's also unclear what the potential for catch-up is. For mental health, I would say the results are very mixed, but suggesting this just our study basically so far that I'm aware of, showing that mental health actually improved among older students as an effect of the school closures. So in the end, you have this inevitable trade-off between learning losses and reducing transmission. And I would say that closing the schools for younger children was probably quite poorly motivated. Older students maybe, and then when exactly you draw the line between younger and older students is unclear, but they say maybe around the age of 12 or something. So, thank you.
Thank you very much. Thank you so much, Jonas, for your very nice presentation. Is there any comments from the floor? I have just a question. Is there any gender difference in the learning losses from your review?
No. Well, students who perform worse tend to do worse off, and those tend to be boys on average. So there's something. It's also like it's quite well established in this literature that girls are more conscientious when it comes to schoolwork. So this thing about like doing your work by yourself, there are some indications that this is. That girls do a better job like being away from school. But it's not completely. I mean, the results are a bit mixed there as well. But on average, I would say that boys probably fared worse. I would say if I had to summarize all the results, as far as I understand them. I can also say you're off. You're muted.
Yes, sorry. Yes, thank you very much, Jonas, for your very nice presentation. Let me go to the next one. I think Maxim Ananyev is not here, so maybe we can go to Joan Madia on migration and health.
I will share my
Joan,
slides.
the floor is yours.
Okay, can you see my slides, right? Or
Yes, that's perfect.
Great. So this is joint work with Catia and Nicodemo from the INAPP Department of Primary Healthcare Science. Yeah, basically we focus on migration for this book chapter, and what we are going to do is, basically to summarize what is the evidence regarding how COVID has impacted migrants and refugees across mostly Europe. And this is basically a summary of the current evidence. So I'm going to show you a series of snapshots that we choose. Today in the chapter, we have a very long description among different areas of health. So I will start showing you that there has been changes also in the migration flows during the pandemic, and this is obviously because lockdowns didn't allow people to move, right? So you can see here in the first figure that during the 2020, there was a massive drop in the inflows of migrants in European countries. For example, one of the biggest drop was for family reasons, moving to another country for family reasons to meeting other relatives. And if you look below, you have the average, also the comparison between 2010, 2019 and the 2020, and you can see also a very similar picture of a very large drop. The largest drop it was basically for countries like Luxembourg, Iceland, and Switzerland, so high-income countries in Europe. Obviously, we were mostly interested with health and mental health. Some of the factors that might explain why migrants have worse mental health or have experienced a larger deterioration in the mental health is because they were already in some precarious conditions. Usually migrants are quite disadvantaged when they arrive to Europe. They struggle to integrate in the host society, especially because they lack jobs, the accommodation is not really good. So some of the evidence, especially the European Parliament, has launched a survey, and they have identified a few mechanisms that might explain why migrants were at higher risk of mental health issues. And especially you can see here that financial insecurity, unemployment, poverty were major drivers of this gap in mental health. But also some protective factors that obviously were lacking as well, like social connections. They have less connections, obviously education and employment or financial stability and so on. So basically here what we have is a descriptive figure where you can see data from a Part Together survey. This is a survey that was conducted by the WHO. And it was especially designed to capture the deterioration in mental health of migrants during the pandemic, and not just migrants, also refugees. So what I'm showing here is basically we have broken down this mental health, this proportion of basically of people that have different symptoms like depressions, worry, anxiety, loneliness, anger, all proxies for mental health. We have broken down by the legal status in the current country where they are. So you can see basically that those that were in some kind of legalized situation because they have the citizenship, because they have permanent documents and so on, were struggling less. So also your legal condition is another driver of your mental health. For example, if I pick one of these indicators, for example, homelessness, you will see that undocumented people were experienced homelessness much more, like 52% of them were reporting some kind of issues. Similarly, sleeping problems with 48 for those undocumented. So the legal status in the country is also a very important factor, and obviously this survey allows to interview, to capture what were like undocumented people. That is usually a very invisible population to some extent. So and these are obviously the people that experience the worst basically conditions of the pandemic due to the situation. So we also know that migrants are more likely to be key workers or essential workers, like, for example, people in transportation, like drivers, or people in retail, like in supermarkets, or even people in the healthcare sector, like nurses and so on. And we know that these people experience the worst in the sense that they have higher risk of mortality because they were in the front line, basically. Just to give you two examples, in Sweden and in Italy, we know that especially people from mid and low income countries, migrants from mid and low income countries have higher risk of mortality. And this was especially because they were employed in these essential works, in essential jobs. But not just basically in the lower strand of the occupational structure, but also in the higher ones. There were a lot of doctors, migrant doctors that were exposed to the COVID, obviously, and they have a higher risk of dying. So just to give you another snapshot, another image, another description of how is the migrant situations. This basically in this map, you can see the share of migrants that are key workers. And the darkest areas is where the highest proportion of migrants are concentrated. And you can see basically that in Central Europe, like in Germany, Switzerland, but also in the north part of Italy, you have a higher proportion of migrants that are key workers, are essential workers. This is basically the people that were in the front line, as I said before. And also England, for example, where we are located now. So they also were quite disadvantaged because they were less likely to be employed in jobs that allow them to stay at home. This is partly because they are essential workers. So you can see here more cross-country differences. Here the darker bars are the migrants, the foreign-born, and the lighter bars are the native-born. For example, if you take the case of Italy, you see that a lot of people, natives, were more likely to work from home rather than, for example, migrants. This is maybe some kind of a special case because the free Mediterranean countries, you can see this remarkable difference, where maybe it's less the case in countries like the Netherlands or United Kingdom. But these are all drivers of why migrants experience a higher mortality rate and have higher issues of mental health, for example. As I said before, also migrants are more likely to be even in the high ranking in terms of occupation and prestige and like things like that. For example, they're more likely to be doctors in countries like Luxembourg. It's quite high also in England and in Belgium and in Sweden, compared to migrants, and they are also more likely to be nurses. So they were also exposed to higher risk of mortality. There was also another problem that there was massive differences in the vaccination, especially migrants were less likely, more reluctant to get the COVID vaccine. And this is another explanation why they have higher mortality rates than maybe natives. And this is obviously a more complicated situation because there are cultural, language, there are legal barriers that obviously can explain these differentials For example, obviously undocumented people were not able probably to go to the NHS in England or to hospitals in Italy because they have the problem, right, that they are not registered, officially registered, and they can be obviously deported. So they have this sort of fear of being exposed, right, to this legal status situation. They also were more concerned. For example, the Muslim communities were scared that the COVID-19 vaccine might have some kind of peak component. So there were also some kind of cultural barriers, even for those that were officially in the country with some kind of legal document. So there were different issues, and this is a huge problem, because if they don't get the vaccine, obviously they're less protected. So what I'm going to show you next is also some migrant integration policy index that show you also how friendly is the healthcare system to migrants, how easy is for them to get into, just to show you more differences between European countries. So the migration policy index is basically an European project where they were trying to cluster, to create some kind of index that summarize how easy is the access to healthcare coverage and services. And what you can see here is that countries like, for example, Ireland, Switzerland, Sweden, Spain, they do quite well. They have a very high score in this index. But if you go maybe to the low part of the ranking, you will see that ex-Soviet countries, like, for example, Croatia, Poland, Ukraine, they have a very low score. So the situation there for migrants is quite tough. Even in countries that are now economically growing a lot, like Latvia or Lithuania, is quite bad, the situation. So you can see that there is a lot of heterogeneities in the access to healthcare. And this is obviously has probably a huge impact on migrant health and well-being. So what we have tried to do in this book chapter basically was to summarize the current situation of migrants, how much they have been struggling in terms of mental health, how much they were at risk of dying due to COVID. But also we tried to show that some kind of the drivers that could explain this differential. And we especially focus on this access to healthcare services. That we think that is really, really important, and it could be done a lot there, at least to alleviate the situation of the most disadvantaged one, that are those that are at the moment undocumented. For example, like refugees that maybe has escaped and they are not legally in the country. So yeah, this is basically what we have done. Just this is the link of our book chapter. And yeah, thank you for your time. So I think there are questions now. So
Thank you very much, John, for your very nice presentation. Is there any comments? I have a comment. I mean, you are in Oxford, so you are based in the UK, and in the UK, actually, you had a Brexit. So, what was the effect of Brexit for the pandemic point of view, for the migration? So, was there any problem in the hospital, for medical doctors, or for something like other?
Yeah, that's a very good question, because yeah, we have two problems actually. It's not just COVID, but at the same time we have the Brexit, and the Brexit has had impacted even the healthcare sector. There is at the moment a shortage of nurses, and this is basically because many of the nurses were migrants, and many of them they permits for working in the country were declined after Brexit. So most of them has gone back to their host, to their home country, and this has created a sort of shortage of nurses. So yeah, there were massive problems even in other sectors, like for example transportation of goods, that were maybe crucial even for hospitals. There has been some issues because most of the drivers, the truck drivers, are also migrants. And at some point they were not allowed to get into the country. So they were even shortages in goods that were maybe essential, like medicines and things like that. So COVID has definitely had an impact on the healthcare system as well. Obviously, we still need to study a little bit more because it gets combined with the effects of the COVID as well, but it definitely has something to do there. Thank you.
Thank you very much. Thank you so much, Joan. I think we can go to the next presentation by Deirdre. So Deirdre, floor is yours. Thank you, Joan.
Thank you.
Please, John, please close your screen.
Sorry.
Yeah. Thank you.
Can you see that okay?
Yeah, sure. That's
Okay,
perfect.
great. Hi, well, thanks very much for having me. Delighted to be here. Thank you, Sergio, for organizing and for everyone else for coming. I'm going to present this chapter on behalf of my co-authors. So this was written with Veronica Cucchiarini, Pete Lunn, myself, and Riccardo Viale. Myself and Pete Lunn work in the Economic and Social Research Institute in Ireland. And I'll start just by introducing the institute a little bit because it's relevant. We're all academics, all researchers, and have adjunct positions in Trinity College in the university, but the aim of the ESRI is specifically to provide research for public policy. So it's an independent research institute that provides evidence for public policy. So part of the research that I present in this was done by us over the course of the pandemic to try and provide some data for policymakers who were trying to deal with this sudden emergence of a pandemic and the policy response that should result from it. Just don't move, there you go. So I'll start with this map, which is a map from the OECD, a living map of behavioural insights units around the world. And you can see the small dots indicate where there's a behavioural insights unit. So there are a lot of them spread all over the world. And when the pandemic really hit, well, I guess in Europe, you know, we really started to be hit by it in February and March 2020, behavioural insights units around the world, within and without government, we're looking towards existing research about what we know about human psychology in order to try and understand how people might respond to this and how they might best be supported in order to make the huge behavioural changes that were required. And why were behavioural insights units, you know, so much at the forefront of trying to understand the psychology behind this? Well, behavior was our main line of defense. So in February, March 2020, there were no treatments, there were no vaccines. The only possible way of trying to reduce the spread of this virus was to change behavior on a mass scale, and to change behavior so radically from behaviors that are completely habitual and completely normal. So suddenly staying very far away from people and social distancing, slightly later on wearing masks and hand washing. And most of these things were not something that people were doing, you know, well, in terms of hand washing, hopefully people were still doing it occasionally, but not every time you went in and out of the shop. Wearing masks is not something most people were used to, and social distancing certainly wasn't. So behavior was our main line of defense. So we needed to look to what we knew about behavior and also look to data to try and understand how people might respond and how we could encourage different behaviors. So the chapter is too big to describe in full in this presentation. So what I'm just going to do is focus on one aspect and talk about going from theory to data to application. So let's talk about a theory first of all. So a collective action problem is when individual actors have personal interests that conflict with collective goals. So that means if you think about COVID-19, it was not in anybody's personal interest or most people's personal interest to no longer see friends and family, to not be able to travel anymore, to not be able to go to the shop without a mask on. And yet the collective goal necessitated this behavior. And really the overall risk of getting and dying from COVID-19 for an individual was pretty small, but the collective risk was pretty big. So those personal interests had to be overridden in order to achieve the collective goal of trying to reduce cases. So when does collective action occur? Well, it occurs when multiple actors work together to achieve a common goal. Now, that is much easier said than done, particularly when it came to the pandemic. Multiple actors didn't just mean many people within one family or even within one community or even within one region of a country. It meant over an entire country and often within countries as well, between countries, globally, there had to be multiple actors working together to achieve a common goal. So the pandemic is a collective action problem and an extremely difficult collective action problem at that. So what can we look at the theory of, or the psychology of how we understand collective action to try and understand in advance of the pandemic how people might respond? Because in February, March 2020, when governments were considering what policies to put in place, really people weren't sure whether the public would generally cooperate with the regulations that were put in place, given they were such huge changes to their daily life, or whether people would actually rebel. So if we look just to the data on collective action in areas that are not to do with the pandemic, but just decades of research on the psychology of collective action, that would tell us that actually most people cooperate when there is a collective action problem. And that's something that actually a lot of people who wouldn't be familiar with this literature may not have predicted in advance, but it was something that the literature said very strongly, that when there is a collective action, most people will cooperate. So you can see on the graph there about 75% of people. Only around 20% of people are free riders, so people who do not engage in the behavior but nevertheless get the benefit from it. But most people have conditions on cooperation. So people tend not just to blindly cooperate unless there is a reason to do so. And there are some factors that predict why people become conditional cooperators or otherwise. So what do we know about cooperation? Well, for individuals to act for the common good, there have to be incentives, disincentives, or some form of coercion. So some reason for them to act, to change their behavior or to cooperate, some reason why it would not be wise to not cooperate, and in some cases, coercion. Now, we have to be careful because coercion can sometimes backfire, in fact, where if people see the coercion to be unfair or unreasonable, they will actually reduce cooperation instead of increasing it. Most people cooperate more out of reciprocity than altruism. And this is quite nuanced, but really important as a psychological mechanism, because people, when they're asked to cooperate, are not doing it for the good of others always, but because they think that other people are doing it. And that you can, see how important that might be for understanding in advance of the pandemic, how people might actually respond to being asked to change their behavior so radically just for the good of other people without necessarily understanding that other people were going to change their behavior as well. Conditional cooperators, so that's 60% of people who will cooperate with conditions, will make sacrifices that are against their own interests, provided others do too. And identity with the group increases cooperation. So a lot of this research is done using experiments and field trials and observation studies where they can control out identity with the group, either by doing it just with in-group members or in fact doing it with people who are complete strangers. But other research shows that the more you identify with the group, the more this increases your cooperation. And communication can establish a base for cooperation. So by that, I mean, when people understand the reason for cooperation, the rules of engagement, essentially, that they're more likely to cooperate. Trust in collective action builds over time. So the more experience you have with cooperation, with the behavior that being asked to change, the more you see that over time, the more likely the collective action is going to occur. But, and this is in the behavioral research, collective cooperation may vary by country, and differences in trust and prior experience can predict cooperation. So in March 2020, around the world, a lot of reviews appeared looking at research on collective action and other behavioral and psychological research to try and understand what might influence people adhering to the policies that were going to be put in place or the public health guidelines. And some of these papers were looked to try and understand how people behave in situations like this. So briefly, what could we say about each of these kind of rules of collective cooperation that might be relevant to the pandemic? And some of these were published as advice to policymakers, as advice to communicators to try and understand or to try and provide advice on how people might behave when policies were put in place. Well, as individuals act for the common good only when there are incentives, disincentives, or some form of coercion, the advice was that the benefits of changing their behavior had to be really clear. So the benefits of wearing a mask, of not going to school, of not seeing friends and family, those benefits had to be made really clear in most countries at least, rather than just becoming a rule. And yet rules are really important to have some form of coercion. I don't necessarily mean fines, but just having a clear set of rules with which there might be at least at a minimum social disapproval if they weren't followed was likely to be important to increase cooperation. That most people cooperate more out of reciprocity than altruism meant that leadership was likely to be very important. So if leaders were putting out health guidance and new changes to rules, but they weren't seen to be following those rules themselves, then it was predicted that this would be likely to reduce cooperation. And in fact, this was seen in the UK after there were some leadership breaches of the rules of public health guidance that actually did in some survey research reduce slightly the levels of cooperation in the public. So leadership and seeing that reciprocity was predicted at the start of the pandemic would be really important for trying to increase cooperation. Conditional cooperators will make sacrifices provided others do. Well, the advice based on this research is that accurate information about social norms needed to be put out. So if public health guidance was put out, but people didn't actually think that others were engaging in the behavior, then they would be less likely to cooperate themselves. So providing accurate information about what were the new social norms and the extent to which other people were actually following them was likely to be important. And I'll talk about some research on that later on. Identity with the group increased cooperation. I think we saw this an awful lot in the communications around policies during the pandemic, is this attempt to try and build an identity. So communication campaigns like "we're in this together" or "do this for friends and family," trying to remind people why these rules were in place based on the previous literature was likely to increase cooperation and was something that seemed to be enacted then in communications campaigns throughout the pandemic. And from the start, behavioral scientists recommended that having trusted, honest, open communication was going to be key to try and establish cooperation. So rather than just having, say, draconian rules or just telling people they had to do this, or not being clear about the numbers of cases, or indeed not being clear about the uncertainty. That was something that, you know, there can be a tendency towards somebody who's communicating to want to say that the science is the science and it is clear and there's no ambiguity. But of course, that wasn't the case, particularly with COVID, where we were learning more and more as the pandemic went on. So actually establishing trusted, honest communication, including communication about uncertainty, was going to be more likely to increase cooperation, and something that was recommended at the start as well. And then trust in collective action builds over time. This, you know, we'd hypothesize is the importance of consistency then in rules and explaining why the rules are in place, and also in having some out for if cases reduce, that rules would actually be reduced. But of course, this may vary by country, including differences in trust and experience. So for example, in some parts of Asia, there was already experience of wearing face masks and already experience of some respiratory viruses that people in, for example, in Ireland had not experienced before to the same extent. There are also differing levels of trust in different countries, trust in the government, trust in public institutions, and all of these also influence all of the factors above. So in around kind of February, March, April 2020, there were a lot of research review papers being put out looking at this type of collective action literature, trying to understand what we know already about cooperation and how it might apply to COVID-19 to try and provide some guidance in communication and in the types of policies that could be put in place to try and increase the likelihood that people would cooperate. So overall, people don't just cooperate, purely out of altruism for their own reasons. So we need a third party to provide cognitive, coordinative, normative, and informational guides. And for the most part, that is the government or large public health institutions like the World Health Organization that people would be looking to guide their behavior, and the behavior of those governments and large public institutions and leaders were likely to play a huge role in whether or not people cooperated with the guidelines that were in place. And another problem with COVID is that a lot of the behaviors were essentially invisible or not so easy to see if people were or were not following them. So that's why we needed to look particularly at this literature to understand what motivated the behavior. Okay, so if we look just very briefly at some data in this, I mentioned that there were a lot of behavioral teams around the world, or not even just behavioral teams, psychologists in universities, behavioral economists in universities, looking at how we could test and apply these principles of collective action. So in Ireland, which is where I'm based, we looked at social distancing, and we looked at different types of messages, including whether you could highlight the risk to others of not social distancing, whether you could try and understand or try and explain exponential growth. So how 3 cases could rapidly lead to 9, could lead to 27, and then purely just information along the lines of this is 2 meters and please stay 2 meters apart. And what we find was those kind of social distancing messages that highlighted risk to others were more effective than purely informational based. And this would be in line with the collective action literature, and something that was then taken up to try and remind people who they were socially distancing for, even if they themselves didn't feel under great risk from the virus, that the risk to friends, family, to keeping restrictions in place for much longer than was necessary was likely to be reduced if they socially distanced. We also carried out a bi-weekly behavioural measure in Ireland, where we carried out a survey of 1,000 people every 2 weeks, and we measured behaviour, where they had been, what they had been doing, if they wore a mask when they were there. And we asked these questions in a very neutral fashion that were not about COVID-19, where we later generated all of the variables to see to what extent people were complying with guidelines or not. So we just asked people to think, yesterday, where did you go? And then once you were there, how many people were also there? And then questions about, was there social distancing? Were people wearing masks? This was really important because it showed what the collective action literature predicted, which is that most people were cooperating. But because we collected variables on psychological factors like how worried people were, or to what extent they believed other people were following the guidelines, it meant that we could also see what factors predicted behavior. And one of the strongest predictors of behavior was actually the extent to which people thought others were following the guidelines. And because we were collecting this data and also making it publicly available in real time, it meant that we could counteract some of the conversation at the time, where particularly media outlets were sometimes saying that there was wide lack of following the rules, wide discretions in people having huge parties, or in traveling wide places during level 5 lockdowns. And we could see from the data that that wasn't necessarily the case. So the data was able to counteract some of that discussion, and then hopefully by showing people what the actual levels of compliance were using trusted, accurate data, perhaps then increasing the extent to which they were willing to cooperate. So certainly the theory on collective action seemed to be borne out in the data, and then potentially some of the accurate information being highlighted might have increased cooperation further to that. And then in Italy as well, there was a lot of behavioural science. I don't have time to talk now about the misinformation research that was done in Italy, but there was a lot of effort done to try and counteract misinformation. But there was also a lot of testing of public health messages to try and encourage people not to change their behavior too rapidly once some restrictions were coming out of place. So looking at messages leveraging loss aversion, and also a recognition of all the effort already put in order to try and reduce the amount of travel that people were doing. And that message about recognition and about recognizing friends and family, what sacrifices have already been made, is using that kind of collective action literature about identity and about gratitude and about clear communication in order to try and encourage people to cooperate. In Japan, there was also research done looking, for example, at how to increase the salience of sanitizers use. So putting huge arrows on the ground and making big red markers where the sanitizer were, and also a message of gratitude to try and increase the social norms, the idea that this is something that is done and this is something that other people are doing, that there is a reciprocity involved, which we know is likely to increase cooperation. They found a large increase in the amount of people who were using sanitizer as a result of this intervention. And then in Bangladesh, they also tested messages leveraging gratitude, pro-sociality and nostalgia to look at the extent to which people would call a doctor if they were experiencing symptoms and self-isolate. So the important thing about these, very few numbers of examples, obviously there are a lot across the world, is that they were predicted on the basis of, or designed on the basis of what we know about the collective action literature, but the data was actually collected and used in the pandemic rather than trying to take something off the shelf. These examples are all examples of where countries actually collected data during the pandemic to try and inform policy in a kind of high pressured time when large changes were being required of the public. But interventions can't be taken off the shelf. So I've given a few examples there, but there are lots of situations where interventions didn't actually work. And this is, I guess, related to my point earlier, is the extent to which we think that behavioral intervention is just an off-the-shelf intervention that can be applied anywhere, or indeed that we can lump behavioral interventions into one simple category is, perhaps debatable, because there are lots of situations where interventions didn't work because of contextual factors, or perhaps because of some of those factors that I mentioned at the start, like the level of trust or experience of the populations in being asked to do these behaviors already. So some interventions worked in one country that didn't work in another. Some interventions worked for one outcome that didn't work for another outcome. And some worked in one context that didn't work in another context. So to give you an example, a lot of the discussion about the pandemic was about collective action at the start in March 2020, and that seemed to be fairly successful in trying to increase cooperation for all the public health rules that we had at the start. And then we saw that kind of spin through into communications about vaccines at the start, asking people to be vaccinated to protect others, be vaccinated because it was the right thing to do, tell people the number of people who were being vaccinated. But now the reviews of the vaccination literature are actually saying, of COVID-19 vaccination literature, the messages that highlighted the personal benefit of vaccination influenced uptake more strongly than the collective benefit. And it does make sense, I guess. There's always the benefit of hindsight, but that does make sense when you think about vaccination as a behavior that's a very personal one, where something is being done to you rather than you just making a decision to, for example, socially distance. That highlighting the personal benefit may seem to make sense more to influence behavior more than the collective benefit. But it shows the importance of actually testing interventions and of not taking things off the shelf without providing data to test them, and how interventions differ depending on the outcome and differ depending on the context. Okay, so some lessons from world globally and from looking at how a theory can move through into data, can move through into application. Well, acquiring and relying on high quality, relevant scientific evidence is important. And it's important in terms of communicating with people if we want to increase cooperation, but also important in terms of relying on scientific evidence, on trying to get evidence that is contextually relevant, that is providing evidence for something that may or may not work, and also the importance of recognizing null effects. If something is assumed to be tried and doesn't have an effect, we're moving on to something else. Providing timely and transparent information about government decisions, evidence, and citizen behaviour may have enhanced trust. I thought it was really interesting in one of the earlier presentations, talking about how people were kind of demotivated when the extension to restrictions extended past what they expected. And I think that was a really important lesson throughout the pandemic, was not to build unrealistic expectations and instead to be transparent about the level of uncertainty. And there was some research we did in the summer of 2020 where we looked at people's expectations for when restrictions were going to lift. And actually the general public were far more accurate in their perceptions when we look back on it now than say some decision makers were about when restrictions were likely to lift. So expectations were certainly important, and providing timely and transparent information to guide those expectations was likely to have enhanced trust, as we saw in the Italian evidence that was presented earlier, to also enhance cooperation. So behavioural interventions, I argue, are not off the shelf and should actually be preceded by diagnostic work. So again, when I mentioned the vaccine study, sometimes interventions were just tested based on prior evidence. Sometimes there was more diagnostic work like surveys and pre-experiments to try and understand people's psychology before implementing an intervention. And for the most part, this is generally more successful than just taking an off-the-shelf intervention. So where possible, I think the pandemic has shown us, guided future behavioural science work as well, is that behavioural interventions should be preceded by this type of diagnostic work and also tested in context. And generally, this would be the summary from the theory that we looked at the start, but then also what we see on the basis of the large body of research that was collected on COVID-19. The behaviour change was helped by, broadly speaking, 4 factors: so social norms, trust and reciprocity, breaking down behavioural barriers, so enabling the use of, for example, hand sanitizer, or enabling people to stay home from work by providing financial aid for people who are going to have a loss in income, using external tools and information to empower the decision maker. So governments providing accurate information on the number of cases and the likely effect of different types of behavior, and then emotion as well. And that's kind of a double-edged sword, because it was impossible not to have an emotional response to the pandemic, with people knowing people who got very seriously ill or who died, but also trying not to leverage emotion too much, where you're overextending risk or overextending the level of optimism. So there's some research on where emotion was an aid and where sometimes emotion was a barrier to trying to help people to cooperate with the public health guidelines that were necessary at the time. And then finally, existing relationships between behavioural scientists and policymakers likely help to bridge the disciplines in some countries. So where there was an existing relationship, either within a government or external to a government, where there was already some level of appreciation of the necessity to collect data to inform policy, is likely to have helped them when the pandemic hit, to allow decision makers to essentially trust the theory of, for example, collective action when it comes to try and incorporate that into communications, but also to amend views where data was collected and it would turn out that some approach that was favoured did not have an effect. So that's a very brief overview of one aspect of the chapter, and I'm happy to take any questions or comments. Thank you.
Thank you very much. Yes, Jonas.
Yeah, sorry. Yes, so I wonder a little bit about this, like this well, complicated relationship between trust, consistency, and also the competence of the policymakers. Because, I mean, if you backtrack, you always run the risk of seeming, at least, if you backtrack on previous measures, you run the risk of seeming incompetent, that you didn't foresee this. And you also have if you're not backtracking, you run the risk of being like prestigious and so on, that your decisions are based on prestige and type of information that you provide is trying to like cover up for previous mistakes. So it seems to be a very complicated issue to try to maintain the right balance there. I'm coming from Sweden. I think that a lot of, especially academics, I think, lost a bit of trust in our public health authorities because we felt that they were too unkeen to backtrack on previous decisions. But of course, that might be a small group of academics who feel like that they don't adjust their communication and their policies in the light of new evidence, whereas people in general might think that, well, they knew what they're doing, and whatever they're doing, even if it's slightly wrong, is probably right. So it might be wrong on the margins, but overall right. So is there like any general lesson to learn about this, that how to both seem consistent and competent, and at the same time adjust? It seems to be very difficult to do.
Yeah, I think that's a really, really good point. I think that goes back to the importance of the clear, honest communication at the start. So trying to communicate uncertainty. So not saying, at the very start, we are definite that we're going to come out of it in 2 weeks, or saying at the very start, we know that this is going to solve the crisis. I think a willingness of decision makers, of policymakers, to actually say when things are uncertain is likely to be really important, trying to increase cooperation. Now, I can't speak for all countries and I don't have data to support this, but I know, for example, in Ireland, there was a lot of scientists, so basic scientists who would be brought on media an awful lot to talk about the changes in the virus and the changes in variants, to try and get across the message that this was uncharted territory, that we weren't quite sure what this virus was going to do. We did carry out some behavioural research looking at whether people would be more likely to continue to cooperate if they had rationales for when certain restrictions would be lifted, which helps both the policymaker to say, well, I'm making this decision now, but I'm telling you in advance I might need to change my mind if X happens. So, if people thought that, okay, if cases rise to 8,000 in a day, then we will have to backtrack on this restriction. It means that a decision maker can stay consistent while also trying to communicate some uncertainty. So I think that is the importance of communicating uncertainty and of putting contingencies in place, and being very transparent about it is something that's likely to increase trust. And indeed, the collective literature would suggest that. All right. Sorry, was there something else I was going to say about it's gone out of my mind. If I think of what I was going to say, I will. But I think it's communication is key.
Thank you so much, Deidre. That's very, very good. Thanks so much. I think we can go to Fabio's presentation. Fabio, the floor is yours.
Yes, thanks.
Sorry, I'm trying to find it. Oh, stop share there, I found it.
Yes, you should stop. Thank you.
I couldn't find out how to stop.
Thanks so much.
Hope you can see my screen, my presentation, and also hope you can hear me and see me.
Yes, that's perfect. Great. Yes.
Is it working? Okay, thank you.
Yes, that's perfect.
Okay, thank you. Good day, everybody. Thank you, Sergio, for organizing this interesting session. Thanks for previously having invited us in contributing to the handbook. And thanks also for granting us the possibility to present our contribution today on COVID-19 and the impacts that the pandemic could have been on inequalities. This contribution has been made together with as you can see, other colleagues, Michele Fabiani and Francesco Scicchitano from the University of Campania Luigi Vanvitelli, Italy, and Federica Alfani and Vasco Monini, who work for the World Bank. As a way of introducing the issue, we highlight mainly what are the main contributions by surveying the literature on the inequality impact from the COVID-19 pandemic that, according to the literature exactly we surveyed, has been found to be significant, and that probably has set in motion a process whose consequences are still to unravel, precisely because, of course, we don't have yet the possibility to use microdata, to exploit microdata for analyzing precisely what could have been the impact of the COVID-19 pandemic on inequality. They start to appear, but they are still scarce. So many of the impacts on inequality and inequalities that could also be considered according to different dimensions, as we will see, most of the times up to today, to the current literature have been analyzed through, for instance, microsimulations, because exactly microdata are still scarce, and so we don't have yet the possibility to precisely estimate the potential COVID-19 impact on, for instance, simply inequality intended in economic terms. Anyway, a point that we could use to summarize independently on the several dimensions you could exploit to analyze exactly the impact on inequalities due to the COVID-19 pandemic outbreak. That is therefore a point common to the evidence, also the evidence that anyways it's still very preliminary, is that it seems that those that were already in vulnerable conditions, especially those from countries for which the confined number of infections and also that had been, according to, due to the COVID-19 pandemic outbreak, affected the most, have seen their working and living conditions more in general deteriorate comparatively faster than other situations. So according to this common evidence to the several dimensions through which the impact in terms of inequalities of the COVID-19 pandemics could be analyzed, that could be obtained from exactly this preliminary evidence, is that the pandemic, rather than having been a kind of exogenous shock, can be instead being considered as something that is endogenous, because it has, in fact, according to the evidence available up to today, exacerbated and accelerated some tendencies that were already existing well before the outbreak of the pandemic. And from the point of view of economic theory, especially for standard mainstream economic approaches, this could raise some troubles, some challenges in general, because, as you know, mainstream approaches typically focuses on identification of exogenous elements that eventually tend to destabilize the ordered functioning of market forces and their equilibrium. Of course, this is an hypothesis we would like as an anticipation of the summary conclusions that will be given during this presentation. In the end of this presentation, we would like to analyze this point more in depth, that is the endogenous nature of the COVID-19 impact on inequality. The problem is that exactly we don't have yet the available macro data that anyway, in some cases we have found, but this was a very recent finding, are starting to appear. So they could eventually, in the near future, exploit it for exactly trying to, at least from the econometric point of view, to exactly provide confirmation on the empirical ground of this endogenous hypothesis that, according to us, is the best hypothesis given the preliminary evidence we have on the impact of the COVID-19 pandemic on inequalities to exactly describe this hypothesis we advance. Whereas in this chapter, we just look at the vast majority of the literature that has been produced since the COVID-19 outbreak on the potential impact in terms of inequality, impacts that we tend to, and this is also, let's say, from the organizational point of view of the work, the way we followed to produce the chapter, exactly the way we organized the work, in the sense we decided to analyze the impacts in terms of inequalities due to the COVID-19 outbreak, looking at multiple dimensions. They usually, you can say, dimensions according to which from a multi-dimensional point of view, inequality could be analyzed, and these are exactly the dimensions that you find listed at the bottom of the slide. We categorize, or we collect towards the principal contributions, the main contributions on the impact that analyze the impact on economic inequality due to the COVID-19 pandemic's outbreak, where economic inequality is as usual measured. This is just univalent inequality, so that is usually measured on using income or consumption. The second dimension we consider, and for which we provide a series of works that are exactly analyzing the issue, that is numbered with 2, is the impact of COVID-19 on health, education, and subjective well-being inequality. And further, we provide a collection of research work on the impact that COVID-19 could have been potentially on, or could have potentially on, gender and ethnic racial inequality. And finally, we also try to provide a collection of empirical evidence works on the impact that potentially COVID-19 could have been on the inequality in the functional distribution of income. The next slides are slides like this one, for instance, for which we have tried to provide examples of the main contributions related to the several dimensions of inequality, for which we try to analyze exactly the potential impact according to the literature that we have surveyed for the several dimensions due to the COVID-19 pandemics, starting from the dimension of economic inequality. Of course, the main result is that the one that could be considered to be the summarizing view of this point related to the impact of the COVID-19 pandemics on economic inequalities, that according to the several works we have analyzed, there has been an impact due to the COVID-19 pandemic that has led to an increase in economic inequalities. For instance, in the tables you find in this slide and also in the following slides, there is indication in the left column of the contributions that are also, of course, listed in some final reference slides, and aside in the following column of the table, there is indication of what could be considered as being the main contribution of exactly the work or the works that are listed, or the contribution that are listed in the previous column. And for instance, it is found by some contributors that low-income countries where population tend to have unequal access to basic services, jobs, markets, and capital are more exposed, being more exposed to the risk of pushing inequality higher when in general a crisis occurs. And according to these works, there has been also, this is exactly also what has happened due to the during the COVID-19 pandemic outbreak. And also, for instance, the main channel for which there has been such an increase in the level of economic inequality has been the channel provided by the labor market. So, for instance, according to some other contributions, the employment loss has been exactly identified as the major channel of impact on household welfare due to the outbreak of the COVID-19 pandemic that has led to exacerbating inequality, especially exactly inequality that could be measured as a result of the labor market outcomes. These are contributions that have concerned groups of countries, but there has been also contribution focusing on specific countries, like, for instance, the one that is listed at the bottom of this table, according to which in Australia and Ecuador, state interventions have mitigated the impact of the pandemic on inequality of income, meaning that following the COVID-19 pandemic outbreak, there has been an increase in such inequalities. And we can provide some other examples of contributions that tend to point once again to towards the direction of an increasing economic inequality as a consequence of the COVID-19 pandemics. For instance, there are studies that provide evidence about, for instance, for Belgium, Italy, Spain, and the UK, an increase not only in income inequality, but also in income poverty. Studies that tend also to show how the COVID-19 impacts amplify the pre-existing inequality between rich and poor countries and between haves and have-nots within countries. And also there have been attempts at estimating through the use of micro-simulation models, and this is exactly the case of the last contribution that is listed in this table, the impact of in general epidemics, but also specifically for the COVID-19 pandemics, of exactly these pandemics on income inequality, using specific indices of inequalities, like, for instance, the Gini index, and, for instance, from authors of the last contribution that is in this table, it has been found that there could be an increase, an average increase in the level of inequality of around, in terms of Gini coefficient, of around 1.1 percentage points following the outbreak of the COVID-19 crisis. So, according to these studies, there could have been an increase in the level of economic inequality, or there could be, we could expect an increase of economic inequality following the COVID-19 pandemic's outbreak. As for
sorry, Fabio, you have 2 minutes left. Sorry for that.
Okay, I try to be faster on the rest of the contributions. As for health in the education and well-being inequality, we could say that also from this point of view, there has been a negative impact according to the surveyed literature stemming from the outbreak of the pandemics. For instance, according to the studies that you find listed in this table, there is there are negative consequences from the effects due to the pandemics on subjective inequalities that has been found in general to deteriorate following the outbreak of the pandemics. Also, pre-existing health and education inequalities tend to increase following the outbreak of the pandemic. As for other dimensions, like for instance, consequences in terms of gender due to the COVID-19 pandemic, there is, as a general result, an increase in already pre-existing differences in terms of gender due to the exactly the outbreak of the pandemic. And this is true also for racial ethnic disparities that tend to be exacerbated according to the studies you find listed in this table due to the outbreak of the crisis. As for finally the impact on the functional distribution of income, we have found instead that from this point of view, there has been much less contributions. We found very few papers and articles that tend to analyze in depth, for instance, what has been the evolution of capital and or labor shares during the COVID-19 crisis. We have found, as mentioned, very few contributions. For instance, just few papers find that firms' exposure to the pandemic has been heterogeneous. In particular, there have been firms that suffered from negative effects due to the pandemic, and others that instead suffered or realized some, in a sense, gains because they were positively affected instead from the impacts due to the pandemic. These differences are found to depend on the sector and or the different business model that is adopted from the field. Anyway, in general, on this issue or regarding this dimension, there is no, not yet a huge number of contributions that could shed a better light on the potential impact of the COVID-19 crisis on the evolution of capital and labor shares. As a summary, as already anticipated in the introduction, since micro-level data started to be recollected only recently, we can, of course, provide, according to the literature that we were able to survey, a very preliminary snapshot that anyway tends to point toward a clear direction. For instance, all those with precarious or formal jobs, but also those who could not conduct their job from home resulted most vulnerable to income loss and poverty during the COVID-19 crisis. Also, we signal in the chapter that there is a disproportionate impact on women and Russian ethnic minorities that tend to further aggravate their already unequal socioeconomic situation, a point that we have mentioned in the introduction as being signaling a kind of endogenous nature of the COVID-19 impact that we'd like to, if able to do that, further explore in the near future. I skip, of course, the long list, a very long list of references, and I thank you all for your attention.
Thank you very much, Fabio. We are perfectly in time. Let me thank to all of you for participating in this very nice session on COVID-19 and labor. Obviously, all the chapters from the presentation have been already published in the Handbook of Labor, which is edited by CLOS, so you can download from the website. Let me also say that we still have some many other interesting sessions in this amazing conference. We have many sessions on migration, on happiness, and many other topics. We have also the presentation of candidates of the ASA job market. For the research presentation, we have two parallel online sessions for the presentation of the ASA job market. They are this, if I will remember, they are this night. That's 10 p.m. at the Berlin time. So stay tuned. We have other 2 full days for this great conference. Again, thank you. Thank you so much for being here.
Thanks very much for organizing.
Many thanks.
Francesco, buongiorno. Hi. Hi to all of you. Hi, Dorothea. Hope to see you again.
Hi,
How are you?
I'm fine.
Good, good, very good. So I'll see you in the next sessions.
I think so. Yes.
Yeah.
Yeah. See you then. Bye.
Yeah. Bye.